Hello. Good morning, everybody. So we realized those lines of Kareena Kapoor from Dr. Alka. I am my own favorite. मैं अपने आप की favorite हूँ. She also suggested that it is better to enjoy the journey rather than the destination, and that's what probably the topic of next presentation is, which says diabetic autonomic neuropathy of gastrointestinal tract, or GUT as we say. Remember, in this topic, GUT does not have full stop and punctuation makes a difference in the topic. It is GUT, that is gastrointestinal tract. Why do I say that it is the journey rather than the destination? The reason is the journey is ongoing for understanding diabetic autonomic neuropathy of gastrointestinal tract. I've been working hard on autonomic neuropathy in diabetes and has talked about cardiac autonomic neuropathy multiple times, and that's why we thought of talking about something which is a rare presentation. So let's go to a case, very important case. 26-year-old woman treated type 1 diabetes, experienced sudden cardiac death while catching a bus. What she had? 16 years of duration of diabetes, type 1 diabetes obviously, wide blood glucose fluctuations, recurrent episodes of severe hypoglycemia, obviously hypoglycemia. Over time she developed persistent orthostatic hypotension, daily falls with systolic blood pressure ranging from 30 to 60 occasionally. Was used to it. This is a real. Her last clinical examination revealed resting tachycardia with a fixed heart rate of 115 beats per minute, fine blood pressure of 110/78 with standing blood pressure of 70/48, and she had no symmetrical absent pinprick and temperature discrimination in stocking. Would we have been able to save her? We'll see the answer at the end. But let's start with the agenda. Introduction, definition, epidemiology, pathogenesis, systems involved, and we'll talk about some. So, diabetic autonomic neuropathy is dysfunction of autonomic nervous system, parasympathetic, sympathetic, or both, in a patient having type 1 or type 2 diabetes, but you need to exclude rest of all causes of diabetic. Very important caveat. Our teacher, Dr. Oza Sahib, used to tell us that when they were students, they were told that if you learn syphilis, you learn medicine. Then when we became students, he said, if you learn autonomic neuropathy, you learn medicine. And as you can see very well, it affects most of the systems of the body, most of the organs of the body, most of the tissues of the body. Something that I like to ponder for a minute or so. What is sympathetic nervous system and what is parasympathetic nervous? So sympathetic nervous system is fight and flight. Whenever a tiger comes in front of you, there are three responses. One is fright. बच्चा डर जाता है सुसु. Second one is fight. Let's fight it out. तो क्या हो? The third one is flight. भाग जाते हैं. कुछ तो करते हैं बचने की. All these things are being managed by sympathetic system. It's very easy to understand now that when the sympathetic system is activated or overactivated as compared to parasympathetic, what happens would be increase in heart rate, severe perspiration, then there would be dilated pupils and everything that you encounter during an hypo. When do you get them? When sympathetic system is overstimulated or parasympathetic system is dampened. What is parasympathetic system? It is rest and digest. Full sleep, sphincters are obviously relaxed, empties the bladder, it empties the anus, it relaxes the sphincters, slows the heart rate and constricts the pupil. Typical nighttime pattern. So what happens when the parasympathetic system is dampened. Everything that you see or read here would go. So, coming to the topic. Why should we recognize diabetic autonomic neuropathy? Consider it as a neglected portion. We believe it is not very significant. All data, and believe me, there are lots of data about diabetic autonomic neuropathy. 25 to 50% die within 5 to 10 years of its diagnosis. Fire mortality is 3 to 5 times higher than even cancer, and marked adverse cardiovascular, renal, and cerebrovascular outcomes. And recently, we have found a close association cardiac autonomic with cardiac failure and CKD. So, pathogenesis, as we always seen with all neuropathies, very classical, because this is also type of neuropathy. Topic is autonomic neuropathy of the gut. Why I am talking about cardiac autonomic? You need to know cardiac autonomic neuropathy before knowing autonomic neuropathy of the gut, because cardiac autonomic neuropathy always precedes the diabetic autonomic the gut. And why so? The reason is neuropathy, as we all know, is dependent upon the length, and which is the longest autonomic nervous system or the nerve of the body, and that is vagus. It starts from the brain, reaches the heart, and then it reaches the rest of the organs. And therefore, when vagus is involved, when parasympathetic system is involved, which is involved earlier in cardiac autonomy, it is the heart which is affected first. Our professor K.C. Dave was a genius pharmacology professor, along with a poet also. He always used to talk about parasympathetic system started with eyes. Then he used to narrate, from eyes you enter to reach the heart. So eyes are affected first, followed by heart, and therefore you need to know the cardiac autonomic neuropathy, which is generally having structural and functional both changes. This is very classical of autonomic neuropathy, and you will find it everywhere. These are all associations of autonomic neuropathy. That's why we say, you know autonomic neuropathy, you know everything. Causes are poorly understood, but risk factors are very clear. Increasing age, duration of diabetes. Further duration, chances of autonomic neuropathy become. Uncontrolled glycemia, especially in type 1, the commonest cause of autonomic neuropathy, whether of gut or of the heart. Hypertension, dyslipidemia, obesity, and of course smoking and micro. Remember, all neuropathy have the basis in microangiopathy, and when we talk about microangiopathy, we need to remember ADAPT and ACCORD, we need to remember UK and other trials which suggested that intensive glycemic control prevented the microangiopathy by 42%. So the answer is very clear what I was going to talk. So the system involved, and we are going to focus on gastroenterology. What are the presentation? It could be any. When it is cardiac autonomic neuropathy, the symptoms would be different, like lightheadedness on standing up or after eating. Remember, we never focus on post-eating, and we rarely think about postprandial hypertension. Both of them are because of cardiac autonomy. And what you need to do, remember this by heart now. Cardiac autonomic neuropathy has image test of reflexes, but you don't need to do now. Just ask the patient to undergo ambulatory blood pressure monitoring, and if he is a reverse dipper, he is having cardiac autonomic. His blood pressure are not falling at night, then the daytime blood pressure, whether he is hypertensive or not, forget about it. His blood pressures are more at night than during daytime. That is what we call reverse dipper. Easiest way to diagnose cardiac autonomic neuropathy, and now lots of associations suggest that they are followed by gastrointestinal neuropathy, they are followed by CKD, they are followed by sudden cardiac death, they are having excessive cardiovascular mortality. abdominal pain or bloating, that we'll see. Screening for diabetic autonomic neuropathy in all patients at the time of diagnosis and every yearly in type 2 diabetes, and 5 years after the diagnosis type 1 diabetes, which is a classical standard screening for any neuropathy. So now, gastrointestinal autonomic neuropathy. How does it present? Esophageal dysmotility, gastroparesis, enteropathy, constipation, fecal incontinence, and gallbladder atony. What's gastroparesis? The time of GLP-1 receptor agonist and gliptin. We now use gastroparesis to treat diabetes, but unfortunately, mask the gastroparesis caused by autonomic neuropathy. And that is why importance of understanding cardiac autonomic neuropathy, because gastroparesis would be masked by the use of drugs. What are the classical symptoms? Classical symptoms are early satiety, fullness, bloating, nausea, vomiting, dyspepsia, abdominal pain. In other words, everything that we see with semaglutide, liraglutide and tirzepatide which is going to come. Very classical, because we are producing gastroparesis, and therefore whenever the patient is on these drugs, just don't understand that this is all because of the drug itself. It could be because of autonomic neuropathy, and therefore send the patient for ambulatory monitoring. Because these symptoms are non-specific and poorly correlated with severity of gastroparesis. But what I want you to understand from this 20 minutes lecture is very important. Wide glucose fluctuations and frequent unexplained hypoglycemia. If your patient was very stable for last 1 year on the same treatment, on the same OHS, same insulin, whatever he is taking, with a very smooth life, very nice regular exercise, no change in his lifestyle, suddenly starts getting wide glucose fluctuation or unexplained postprandial hypoglycemia, time for you to realize that he is developing gastroparesis, because apart from the non-specific symptoms that I told you, the most important symptom of gastroparesis, wide glucose fluctuations and frequent unexplained. Start thinking about in your practice this symptom, and you will be able to catch up gastroparesis very early, and that would smooth out your diabetes management, because here you will be struggling to manage. You have seen such cases many a times. Gastroparesis, you should remember, also alters the timing and extent of carbohydrate and medication absorption. Right? Even the thyroid tablet gets absorbed very late, and there is erratic control of thyroid hormone. Certain medication can also cause gastroparesis, and that we know. Physical findings are not very specific. We need to exclude gastric outlet obstruction, irritable bowel disease, and inflammatory bowel disease, and you can do it only if required with the help of specific investigation. Remember, investigations that now I am going to do are not indicated to diagnose gastroparesis or to diagnose gastrointestinal autonomic neuropathy, because it can be easily identified with the help of symptoms, fluctuating blood sugars, and simple ambulatory blood pressure. So, what are the investigations? Before we go for any other investigation, we must look for the HbA1c, whether it is controlled or not, because as I told you previously and will tell you again, it is intensive glycemic control which is very important. There are no laboratory studies, but you require HbA1c and glucose level. However, the gold standard test for gastroparesis still remains the scintigraphy of digestive solids at 15 minutes interval for 4 hours. After the gold standard, time consuming, not readily available and costly, but we should know it. The normal rates of gastric emptyings are 37 to 90% gastric emptying at 1 hour, 30 to 60% at 2 hours, and 0 to 10% should remain after. Is more than that, gastric emptying delayed. Remember, whenever you send for scintigraphy, and it is available in Ahmedabad also now and all across the metros. So if whenever you send, sugars should not be highly uncontrolled, because high fasting blood sugar itself can cause gastroparesis. Patients should obviously avoid taking pro-motility agents, anticholinergics and opioids several days before, and smoking has to be. Are there any alternative tests? Non-radiographic tests? Yes. These tests are recently available in Delhi and Mumbai. Recently, the use of 13C octanoic acid or acetate breath test are being recommended, and they are very easy to perform and diagnose the gastroparesis very easily. There is a C13 radio-labeled meal that is absorbed from the duodenum, converted into C13CO2 in the liver, and released during respiration. And tidal breath samples are collected, and that would decide the gastric emptying. There are wireless motility capsule, we call it capsule endoscopy, and that can also help you diagnose the gastroparesis. This is more commonly useful for diabetic autonomic neuropathy in the GIT presenting as constipation. How do you manage? Frequent small meals rather than conventional meals, so that the food, large amount of food does not lie in the stomach for a long time. That is the best non-pharmacological measures. Apart from that, avoidance of any drugs like anticholinergic agents, opioids, tricyclic antidepressant, and most importantly, GLP-1 receptor. Any pharmacological treatment, the only approved drug in FDA is metoclopramide. We may use domperidone. FDA has not approved domperidone at present, but you can use domperidone in India as it is available. So prokinetic agents, erythromycin has shown to give excellent results. There are other different modalities about which may not go into detail. Gastric electrical stimulation for relief for nausea and vomiting, and placement of gastrostomy. So this is classical treatment of gastroparesis. You'll find this chart everywhere. Mild, moderate and severe. In mild cases, metoclopramide. In moderate cases, erythromycin. And in severe cases, you have to go further. Coming to constipation, measurement of transit time, as I told you, with the capsule endoscopy is very useful for diagnosing constipation secondary to diabetic autonomic neuropathy. Treatment is very simple, high fiber diet. Commonest is isabgol or xylem, which is psyllium, which is very, very useful, and then osmotic laxatives. Coming to pathogenesis of diabetic diarrhea, we all know, of course we forget it many times, but we all know nocturnal diarrhea is very classical of diabetic diarrhea. Whenever a patient has to get up at night for passing stool, and you have ruled out infective diarrhea. So it is not of a couple of days story, it's a story of a month or more than a month, and patient is not dehydrated. It is definitely because of diabetic autonomic neuropathy, and you don't need to evaluate, go for fancy investigation like stool routine micro or endoscopy and whatnot. You simply again go for ambulatory blood pressure monitoring. Nocturnal diarrhea has to be because of diabetic autonomic. Treatment would be fluid electrolyte management. Nutritional deficiencies are to be targeted. Treat specifically if found, that is SIBO is found, you can give antibiotics like Rifagat. Loperamide may be used, but remember post-diarrheal distension is very common. Clonidine has been tried just like in cardiac autonomic neuropathy, where clonidine is a drug of choice. Same way it is being tried here. Genitourinary will skip. So, last two slides. Do not forget, ADA recommends a target HbA1c of less than 7 as appropriate for most non-pregnant adults. A lower level may be acceptable. Maintaining near normal glycemic control early in the course of diabetes would prevent the development of diabetic autonomic neuropathy, whether cardiac or GI. In type 1 diabetes, there are undisputed evidences about intensive control and prevention of diabetic autonomy. In type 2 diabetes, the data is not conclusive, and therefore Like Steno study suggested, you require multi-system approach in the form of diet, exercise, glycemic control, control of risk factor like smoking, hypertension, lipids, bariatric surgery may help. So there are multiple areas for future research like sensitive and specific screening. Now ambulatory blood pressure monitor has come out with the best screening. What about this lady? Answer is simple. A very wonderful control, intensive control at the time of diagnosis would have prevented all these things and prevented death also. So type 1 diabetes, intensive control is absolutely necessary. Diabetic autonomic neuropathy remains prevalent in individuals with diabetes, and many studies have shown 42% prevalence. It has a broad spectrum clinical forms and is associated with morbidity. Gastroparesis presents as early satiety, abdominal pain, nausea, postprandial vomiting and bloating. Enteropathy or colonic hypomotility may present as profuse watery diarrhea at night. Gastric emptying is the most commonly measured by scintigraphy. However, ambulatory blood pressure monitoring is the simplest way. Non-pharmacological and pharmacological measures are available. So that's where I'll stop. Thank you very much, Diabetes India. Thanks, Chairman. Thank you.